इधर जा, ये वाला इसको ये कर, आगे के दिन से नहीं चाहिए, कनेक्टेड है ना,
वो प्लग
डोर बंद कर, नहीं चल रहा है इधर, चलिए थैंक यू। हुआ क्या? छोटा विंडोज भी करना है क्या? वैसे दिखा दे, वो ऐसे क्यों किया?
ये तो होना तो
चाहिए तुझे? हाँ मैं लेट हो गया। वो एडिट कर देना। हाँ Good morning, everyone. Today's seminar is on the topic of skeletal maturity indicators. I'll be covering this topic under following headings: introduction, history, methods to assess the skeletal maturity, radiologic methods, biochemical methods, conclusion, and references. So, what is growth? There is no universally accepted definition of growth. Various clinicians have defined growth in various ways. So, Profit defined growth as an increase in size or number. Todd defined growth as increase in size. According to Moss, growth is change in any morphological parameter which is measurable. And what is development? So development, according to Todd, development is progress towards maturity, and Moss defined development as all naturally occurring unidirectional changes in the life of an individual from its existence as a single cell to its elaboration as a multifactorial unit terminating in death. So human growth is not a steady and uniform process. Different parts of human body grows at different rate and different amount per year. So there are periods of rapid acceleration of growth which are termed as growth spurts. So physiological alterations in hormonal secretion is believed to be the cause of this acceleration of growth. So there are different periods of growth. The first one is the growth period, growth spurt, which is just before the birth. The second is 1 year after the birth. Then mixed dentition growth spurt, which occurs at the age of 8 to 11 years in boys and 7 to 9 years in girls. Then pubertal growth spurt, which occurs at the age of 14 to 16 years in boys and 11 to 13 years in girls. So this is a graph showing various growth spurts. The orange region shows the growth which occurs after the birth. The purple region shows the mixed dentition growth spurt. The yellow one shows the pubertal growth spurt. The pink one shows the post-pubertal growth, and the red one shows the growth completion. So the peak of the pubertal growth spurt is termed as peak height velocity. This is the time when the maximum growth occurs, and this is the ideal time to start the growth modulation. So peak height velocity is reached earlier in girls than in boys, and hence the functional appliance therapy should be started earlier in girls to take the advantage of this adolescent growth spurt. So coming to clinical significances of growth spurts, so the knowledge of growth spurt can be used to determine whether the growth changes which are occurring are normal or these are abnormal. Then interceptive orthodontic procedures can be undertaken during this period of growth spurts, and hence the severity of developing malocclusion can be reduced. Then functional appliance therapy should be started in late mixed dentition stage in girls, and in boys it should be started in early permanent dentition stage. So arch expansion should be carried out during the period of maximum growth, and the orthodontic surgery should be carried out after the growth cessation. So the pubertal or adolescent growth spurts, the timing and the recognition of the last and the most important, very important in the perspective of orthodontics. So in females, and it lasts for short duration, that is for 3 to 4 years, it lasts for longer duration, that is 4 to 5 years. Somatic growth rate is seen during this pubertal growth spurt, and the accelerating phase of the growth may last for up to 2 years. And after the 3 to 4 years of the this end of this growth spurt, the active growth ceases. So coming to concepts of chronological age and biological age. So chronological age is the amount of time since the birth or conception, and the wide individual variation can be seen in the timing of the pubertal growth spurt with respect to chronological age. Hence, it is not a reliable indicator for maturity status of a child. So this has led to the concept of biological age or physiological age, which is progress towards various developmental markers or stages. So it has reduced timing of variability, and hence it is a reliable indicator of child's maturity. So, physiological age or biological age can be estimated by maturational status of various systems in the body, like somatic systems, sexual, skeletal, and dental systems. Somatic maturity is annual growth increment in height or weight. Sexual maturity can be estimated using secondary sexual characteristics, and is estimated by evaluating the skeleton of an individual. So the certain bones in the body, they show organized events of ossification, and degree of ossification in these bones the examination of degree of ossification of this bone can lead to determination of the skeletal maturation, which can be done using radiographs. So why to study skeletal maturity? Treatment in the growing patients is the harnessing the growth, and unless we know the exact status of growth both in magnitude as well as in direction, treatment will be futile. So the maturational status of patient have considerable effect on diagnosis of the malocclusion. Treatment planning also gets changed based upon the maturational status of a child, and treatment outcome also gets altered. So it is important for us to study the skeletal maturity indicators. So ideal requirements of skeletal maturity indicators, methods, the methods which are used to determine the skeletal maturity indicators should be safe, It should be accurate, simple to carry out, cost effective, and non invasive. It should require minimum armamentarium, minimum radiation exposure should be there. The method should be valid over the time and over across all age groups, and the stages of maturity should be well defined and they should be easily identifiable. Coming to various methods of skeletal maturity, various methods are there for assessment of skeletal maturity of an individual in orthodontic practice, which can be broadly classified into radiologic methods and biochemical methods. So the biochemical methods, these include the assessment of biomarkers present in the gingival clavicular fluid, that is GCF, saliva, urine, or serum. The radiological methods, in which the 2D methods include spatial hand wrist radiographs, then IOPA, use of IOPA for determining the MP3 staging. Then lateral cephalogram can be used to determine the skeletal maturity using cervical vertebrae and frontal sinus. Then OPG can be used to determine the skeletal maturity using tooth mineralization stages. And occlusal radiograph is useful for determination of mid-palatal suture ossification stages. There are 3D radiologic methods as well. So use of CBCT can be done to evaluate the skeletal maturity based upon the volume of cervical vertebrae and volume of frontal sinus. So, what is the basis of skeletal maturity assessment by radiographs? It is that at the every bone goes through various stages of maturation, and these changes can be predicted by using radiographs. Different ossification centers, they appear at different times at different sites, and the order, rate, time, and appearance and progress of this ossification at various ossification centers occurs in a predictable sequence. So virtually any bone in the body can be used to determine the maturational status, but certain anatomical sites are more suitable for skeletal maturity assessment. These sites should have they should be easily accessible. The region should be small, and to restrict the radiation exposure and expenses. And the site should have many ossification centers which ossify at separate times and which can be standardized. So first we'll see the historical review of the skeletal maturity indicators. So in the year 1895, Roentgen discovered X-rays. In the year 1896, Roland was the first one to give. In the year 1930, Scammon studied four major tissue systems and gave Scammon's growth curve. In the year 1932, Hellman was among the first ones who recognized that the different rates of growth occurs in different parts of the body. In the year 1936, Flory gave the classification of adductor sigmoid is a good guide for pubertal spurt. In year 1955, Nanda reported that the facial growth lags slightly behind in height during pubertal spurt. In the year 1966, Hunter reported that the carpal bones as most satisfactory sites for determining the skeletal maturation. In 1973, Demirdjian gave the dental age assessment based upon the calcification stages of teeth. In the year 1976, Grave and Brown stated that the peak height velocity occurred at about the time of epiphyseal capping in fingers, radius, and ossification of sesamoid and hamate. In the year 1979, Hag and Terenga conducted a study on skeletal changes of hand wrist as an indicator of pubertal growth spurt. In the year 1979, Fishman conducted a study to determine the chronological versus skeletal age changes as an indicator of pubertal growth spurt. In the year Fishman developed a system of evaluation of skeletal maturity from hand wrist radiograph. And in the year 1944, Bernal Revello, they studied the relationship between skeletal maturity and approximation of mid-palatal photographs of hand wrist and cervical vertebrae. In the year 1998, et al. Made the use of dental X-ray film and record the ossification events in the middle access the pubertal growth spurt. In the year 2002, Bassetti et al. Modified the CVMI stages given by Hassel and Furman. So coming to hand wrist radiographs, there are various methods of assessment of skeletal maturity, but the use of hand wrist radiographs is commonly done, and it is so anatomy of hand wrist radio. First, we'll see the anatomy of hand wrist radiographs. So hand wrist is made up of four groups of bone: the distal ends of long arms of forearm, the carpals, metacarpals, and phalanges. So the distal projections on the medial side is ulnar styloid, and on the on the distal side it is radial side styloid. There are 8 carpal bone present in the hand wrist radiographs, which are arranged in the 2 rows, proximal row and the distal row. In proximal row, we can see sphenoid, lunate, triquetral, and pisiform bone, and in the distal row, we can see trapezium, trapezoid, capitate, and hamate. All these bone ossify from one primary center. Coming to metacarpals, these are 5 bones, and they have one primary ossification center in the shaft, and secondary center is present on the distal end. Then there are phalanges, which are 3 in each finger and 2 in thumb. These are again arranged in the 3 rows: proximal phalanges, intermediate phalanges, and distal phalanges. So various methods to determine the skeletal maturity using hand wrist radiographs are the Atlas method by Grulich and Pyle, which is a comparative method, and the individualized methods include Jog, Grave and Brown method, Singer's method, Fishman skeletal maturity indicators, and Hag and Terranger method. So usually all these methods of method, they rely on the stages of development of epiphysis. These stages include: in the stage 1, the epiphysis and diaphysis are of equal width. In stage 2, the epiphysis caps over the diaphysis, and in stage 3, there is fusion between the epiphysis and diaphysis. So first one, we'll see the Atlas method by Grulich and Pyle. So Grulich and Pyle, they published an atlas containing the photographs of radiographs of hand wrists of children of various groups, and there were separate sets of photographs for male patients as well as for female patients, and the patient's radiograph is matched with the on the overall basis with the photographs which are present in this atlas. In these pictures, the middle one is the hand wrist radiograph of a patient with a chronological age of 14 years. The one which is on the left side is a male standard 25 radiograph, which is present in the Grulich Pyle atlas. And which is on the right side, it is a radiograph of a male standard 26, which is present in the atlas. And on careful observation, we can see that the X-rays of a patient, it meets the criteria, which is criteria of the male 25, that is the one which is on the left side. Then coming to Jog, Grave and Brown method. So Jog, they divided the skeletal development into 9 stages using 14 ossification points, and the appropriate ages for each of these stages was given by Schoff in the year 1978. So coming to stage 1, it is a stage physis and diaphysis of proximal phalanx of the index finger are of equal. In stage 2, epiphysis and diaphysis of middle phalanx of the middle pubertal growth spurt. It occurs at the age of 12 years. In stage 3, ossification of hamular process of hamate occurs. Ossification pisiform, and the epiphysis and diaphysis of radius are equal. Then stage 4, in mineralization of ulnar sesamoid of thumb and increased ossification of the hamular process. This stage beginning of pubertal growth spurt. It occurs at the age of 13 years in males and at the age of 10.6 years in female. Then stage 5, it is the capping of epiphysis and diaphysis phalanx of the middle finger and proximal phalanx of the thumb and radius. This age marks the peak of pubertal growth spurt, and it occurs at the age of 14 years in male and 11 years in female. Then in stage 3, there is union between epiphysis and diaphysis of distal phalanx of the middle finger. This stage marks the end of pubertal growth spurt and occurs at the age of 15 years in male and 13 years in female. Then stage 7, there is union of epiphysis and diaphysis of proximal phalanx of the middle finger. Then stage 8, there is union of epiphysis and diaphysis of middle phalanx of middle finger. And stage 9, this includes fusion of epiphysis and diaphysis of radius. Now we will see the Singer's method. In the year 1980, Julian Singer proposed a system for hand wrist radiograph assessment, and this system helps the clinician to rapidly arrive at to determine the maturational status of an adolescent patient. This system has 6 stages. So absence of pisiform and absence of hook of hamate, and the epiphysis of the proximal phalanx of second finger is narrower than the diaphysis, and this occurs 1 year before the beginning of peak of pubertal growth. The stage 2 is a prepubertal stage, which is characterized by initial ossification of hook of hamate and initial ossification of pisiform. And in this stage, epiphysis and diaphysis of proximal phalanx of second finger are equal. This stage is just beginning of pubertal growth spurt. Stage 3 is the stage calcification of ulnar sesamoid, increase in calcification of hook of hamate and physis of proximal phalanx is increased in the gro- growth spurt. Stage 4 is the pubertal stage of ulnar sesamoid, and the capping of epiphysis and diaphysis of middle fingers of third finger occurs in this stage, and this stage is the accelerating phase of pubertal growth spurt. Now coming to stage 5, which is a stage of pubertal deceleration. In this stage, we can see fully calcified ulnar sesamoid, and the fusion of epiphysis of phalanx of the third finger occurs, and the epiphysis of radius and ulna are not fully fused in this stage. Stage 6, this is a stage of growth completion where there are no remaining growth sites seen, and the fusion of epiphysis of radius and ulna with the respective shafts can be seen. Now we'll see the Fishman's skeletal maturity assessment method. In the year 1982, Fishman gave 11 stages of maturity indicators by utilizing 6 different sites in the hand-raised radiograph, as which can be seen in this picture. The 6 sites are proximal phalanx of the middle phalanx of the middle finger, distal phalanx of the middle finger, the sesamoid bone, the radius, and the medial phalanx of the fifth finger, that is the little finger. Then the Fishman systems of interpretation 3 are included in this stage. Then in the SMI stage, of adductor sesamoid and thumb. The SMI stage 5 to 7 characterized by the capping of epiphysis and diaphysis. And the SMI stages 8 to 11, there is fusion of epiphysis and diaphysis. So we'll see the stages. In stage 1, the proximal phalanx of the middle finger shows equal width to the epiphysis or diaphysis. In stage 2, the width of epiphysis is equal to that of the diaphysis in the middle phalanx of the middle finger. Then in stage 3, the middle phalanx of the fifth finger, that is the little finger, is equal. The epiphysis and diaphysis of the middle phalanx of the fifth finger are equal in length. In stage 4, there is appearance of adductor sesamoid. In stage 5, there is capping of epiphysis and diaphysis in distal phalanx in the distal phalanx of the third finger. In stage 6, there is capping of epiphysis and diaphysis in the middle phalanx of the middle finger. In stage 7, there is capping of epiphysis and diaphysis of the middle phalanx of the fifth finger. In stage 8, this is a period of peak height velocity. In stage 8, there is fusion of epiphysis and diaphysis in the distal phalanx of the middle finger. In stage 9, there is fusion of epiphysis and diaphysis in the proximal phalanx of the middle finger. In stage 10, there is fusion between the epiphysis and diaphysis of middle phalanx of the middle finger. And in stage 11, there is fusion of epiphysis and diaphysis of radius can be seen. So this is schematic representations of Fishman's 11 stages of maturation using hand-raised radiograph. So the scheme for hand-raised radiograph observation. So for the maturity evaluation, on first only the key stages are checked rather than going in the sequential order. This leads to rapid identification of the applicable stage. So the first step is to determine that whether the abductor sesamoid has appeared or not. If the abductor sesamoid is not present, then the applicable SMI will be the one which signifies the equal width of epiphysis and diaphysis rather than capping. And if the sesamoid is visible, then either the sesamoid or the stages which are associated with capping and fusion will be applicable. Which in 1982, Hagen Terenger carried out a longitudinal on 212 Swedish children, and they analyzed the skeletal development from hand-raised radiographs by taking annual radiographs between the age 6 to 18 years. The assessment is done for ulnar sesamoid of the first finger. Also, the other three that is middle phalanx, the distal phalanx of the third finger, and the distal epiphysis. Sesamoid is usually attained during the acceleration period, that is the onset of peak height velocity. Then there are five stages of ossification of middle phalanx of the third finger. The MP3F stage. In this stage, the epiphysis is as wide as the metaphysis, and it is attained before the onset of peak height 40% of subjects, and peak height velocity by many others. 3FG state, the epiphysis is as wide as metaphysis, and distinct medial or lateral border of epiphysis forming the line of demarcation at right angle border can be seen. This is attained at or 1 year after the peak height velocity. The G stage, in this stage, the sides of epiphysis are thickened and they also caps its metaphysis for age distally at one or both the sides. It is attained at 1 year after the peak height velocity. Then MP3H stage. In this stage, the fusion of epiphysis and metaphysis has begun, and it is attained after peak height velocity, but before the end of growth spurt by practically all the boys and about 90% of the girls. Then MP3I stage. In this stage, fusion of epiphysis and metaphysis of middle phalanx is completed, and at the end of pubertal growth spurt in all the subject except the few girls. Of epiphysis and diaphysis is completed in the distal phalanx of the third finger, and it is attained during the acceleration period of pubertal growth spurts by all the subjects. I stage. In this stage, a fusion of epiphysis and metaphysis has begun, and the end of pubertal growth spurt by about 80% of the girls and 90%. Then RIJ stage. In this stage, the fusion is almost complete. Still, a small gap at one or both the margins can be seen. And in RJ stage, the fusion of epiphysis and metaphysis is completed. The RIJ and RJ stages are not attained at the end of pubertal growth before the end of pubertal growth spurts by any of the subjects. So this is a diagram showing the stages of Terranger, which shows the five stages of middle phalanx, the one stage of the distal phalanx of the middle finger, the sesamoid bone, and the three stages of the radius. Now coming to intraoral periapical radiographs. So this IOPA can be used for maturity assessment with the middle phalanx of the third finger. So Hassam et al. In the year 1998 gave the MP3 staging. So MP3F stage of Hassan et al. Included the epiphysis is as wide as the diaphysis, and it marks the start of the curve of pubertal growth spurt. MP3G stage is acceleration part of the curve of pubertal growth spurt. In this stage, distinct medial and lateral border of epiphysis can be seen. MP3G stage, it is a point of pubertal growth spurt. In this stage, the sides of epiphysis are thickened and it caps its metaphysis, and sharp edges distally at one or both sides can be seen. In MP3H stage, it marks the deceleration part of the growth of pubertal growth spurt, and there is fusion of epiphysis and diaphysis has begun. And in MP3I stage, the end of pubertal growth spurt, and in this stage, the fusion of epiphysis and diaphysis is completed. So in the year 2002, Rajgopal et al. They modified some additional features other than those which were given by Hack and Terranger. They gave additional bone stage between MP3H and MP3I and called it as, and they conducted a study to compare the modified MP3 stages and cervical vertebrae maturation index. So modified MP3 staging. In MP3F stage, the ends of epiphysis are tapered and rounded. The metaphysis shows no undulation, and there is radiolucent gap between epiphysis and metaphysis. In MP3FG stage, the metaphysis it begins to show the slight undulation, and the radiolucent gap between epiphysis and metaphysis is wide. In MP3G stage, there is a marked undulation in epiphysis giving cupid bow appearance, and the radiolucent gap between epiphysis and metaphysis is moderate. In MP3H stage, angle to distal border, the epiphysis begins to narrow. Slight convexity seen under the central part of metaphysis, and the typical cupid bow appearance of the metaphysis is not seen in this stage, but slight undulations may be present, and the radiolucent gap between epiphysis and metaphysis is narrow. Coming to MP3HI stage, in this stage, the metaphysis shows smooth convex surface, almost fitting the reciprocal concavity of the epiphysis. The radiolucent gap is insignificant in this stage, and there is no undulation in the metaphysis, and the superior surface of epiphysis shows smooth concavity. And now the last one, that is MP3I stage. There is no radiolucent gap seen, and the dense and radio epiphyseal line can be seen in this stage. Coming to lateral cephalogram can be used to determine the skeletal maturity using the cervical vertebrae. So, in the year 1995, Hessel and Furman developed a system of skeletal maturation determination using cervical vertebrae. So the shapes of cervical vertebrae differ at each level of the skeletal development. This provided a means to determine the skeletal maturity of a person and thereby assessing whether the growth is remaining. There is a possibility of growth in the patient or not. So the bodies of the cervical vertebrae C2, C3, and C4. They initially they are wedge shaped, then they become triangular, and then at last they become squarish in shape. In addition, all as the person matures, and there is and the when the person is mature, the inferior border of the vertebrae are become concave, and the curvatures which appear on the inferior borders, they seem to appear in a sequential manner in C2, then C3, and then C4 as the person matures. So coming to stages given by Hessel and Furman, the stage 1 is a stage of initiation. In this stage, 80 to 100% of adolescent growth is expected. The inferior borders of C2, C3, and C4 are flat. The vertebrae are the wedge shaped, and the vertebral borders are taper from posterior to anterior. The stage 2 is the stage of acceleration. In this stage, 65 to 85% of adolescent growth is expected. Is developing in the inferior borders of C2 and C3. The inferior border of the C4 is still flat, and the bodies of C3 and C4 are nearly rectangular in shape. In stage 3, it is a stage of transition. 25 to 65% of adolescent growth is still expected. The distinct concavities can be seen in the inferior borders of C2 and C3, and the concavities are beginning to develop in the inferior border of C4. And the bodies of C3 and C4 are rectangular in shape in this stage. Now, in stage 4 is the stage of deceleration. In this stage, 10 to 25% of adolescent growth is expected. Distinct concavities can be seen in now C2, C3, and C4 vertebrae. And the vertebral bodies of the C3 and C4, they have become more squarish in shape. In this stage, 5 to 10% of adolescent growth is expected, and the more accentuated concavities can be seen in the inferior borders of C2, C3, and C4. The bodies of C3 and C4 are nearly square to square in shape in this stage. And the stage 6 is the stage of completion. Little or no adolescent growth can be expected in this stage. Deep concavities as seen in the inferior borders of C2, C3, and C4, and the bodies of C3 and C4 are square in shape or greater in vertical dimension than in the horizontal dimensions. This is a diagram, a schematic representations of the Hassel and Furman stages of cervical vertebrae maturation. 2005, Bessetti et al. They modified the stages which were given by Hassel and Furman. So CVMI stage 1 as given by Hassel and Furman. In this stage, the lower borders of all cervical vertebrae are flat. The bodies of the both C3 and C4 are trapezoid in shape, that is appearance of wedge of cheese. And there is a peak in mandibular growth will occur on average of 2 years after this stage. Then CVMI stage 2, the concavity is present at the lower border of C2. The bodies of both C3 and C4 are still trapezoidal, resembling the wedge of cheese, and the peak of mandibular growth will occur on average 1 year after this stage. The concavities at the lower borders of both C2 and C3 are present. The bodies of C and C4 then become trapezoid or rectangular horizontal in shape, and the peak of mandibular growth will occur during the year after this stage. And the CVMI stage 4, cavities of lower borders of C2, C3, and C4 are present. The bodies of both C2, C3, and C4 are rectangular horizontal in shape, resembling the bar of soap, and the peak of mandibular growth has occurred within 1 or 2 years before this stage. Then CVMI stage 5, the concavities of the lower borders of C2, C3, and C4 are present. At least one of the body of C3 and C4 are squared in shape, appearing a marshmallow, and a peak of mandibular growth has ended at least 1 year before this stage. And then CVMI stage 6, the concavities of the lower borders of C2, C3, and C4 are evident in this stage. At least one of the bodies of C3 and C4 is rectangular vertical in shape, and the peak in mandibular growth has ended at least 2 years before this stage. So this article titled Quantitative Cervical Vertical with Normal Occlusion, a Mixed Longitudinal Study, which was published in AGO in 2008. In this article, Chen et al. They established the method of quantitative assessment of cervical vertebral maturation in adults. So they took three parameters, which is the angle of concavity in the C2 vertebrae. Then the second parameter is the ratio of anterior height and posterior height of the C3 cervical vertebrae, and the third parameter is the ratio of height and width of C4 vertebrae. And by taking these three morphological variables, the quantitative CBMI stages system, including four maturation stages, were established. So this is a table of values which represents the all the three parameters from the stage, which represents the values of all the three parameters from stage 1 to stage 4. So QCBM stage 1 is it correlates with the period of accelerating velocity of the growth. In QCBM 2 is the period of high velocity. QCBM 3 is the period of decelerating velocity, and QCBM 4 is the period of completing velocity. Now, coming to maturational assessment, development of frontal sinus in relation to the somatic and skeletal maturity was analyzed by Sabin et al. They marked the frontal sinus on lateral cephalogram, and the highest point and the lowest point, that is SH and SI points, were marked, and the maximum width of the frontal sinus was assessed, and they concluded that the final size of frontal sinus varied considerably. Enlargement of frontal sinus exhibited a well-defined peak, which occurred on average of 1.4 years after the body height peak. And in comparison with skeletal maturity, 60% of the subjects reached the sinus peak during the skeletal maturity stages, that is MP3G stage and MP3H stage. Now, coming to use of orthopentamogram for assessment of skeletal. Mineralization can be assessed on OPG as an indicator of skeletal maturity. Various researchers have carried out extensive research to correlate the skeletal age with the dental age, and it is believed that the stages of root formation and mineralization have close relationship with the skeletal maturation of an individual. So in the year 1980, Chatkov et al. They gave a system method of determining skeletal maturity based on the mineralization of a lower canine. So in this, the stage C is the enamel formation completed at the occlusal surface and dentin formation has started. In stage D, the crown formation is completed and the root formation has commenced. In stage E, the root length remains shorter than the crown height. In stage F, the root length is equal or greater than the crown height. In stage G, the apical end is partially open, that is in the distal root of in the molars, and in stage H, the root apex is completely closed. Coming to Nola's stages of tooth development, where the stage 0 means the absence of crypt, the stage 1 presence of crypt, stage 2 initial calcification, stage 3 one-third of the crown is completed, in stage 4 two-thirds of the crown is completed, in stage 5 the crown is almost completed, in stage 6 is completed, in stage 7 one-third of the root is completed, in stage 8 two-thirds of the root completion is there, in stage 9 the root is almost completed and the apex is open, and in stage 10 the root formation is completed and with close apex. Coming to Demirijan methods of dental calcification. So Demirijan developed a method for assessing dental maturity using the radiologic appearances of mandibular teeth, that is from incisor to molars, and each tooth was rated according to the developmental criteria. So 8 stages from stage A and H were from stage A to H were described. So stage A is the initial crown calcification is seen. In stage B, the occlusal surface is fused. In stage 3, the occlusal surface is completely formed. In stage 3, the crown formation is completed up to cemento-enamel junction. In stage E, in uniradicular teeth, the root length is less than that of the crown length, and in the molars, the bifurcation is visible. In stage F, the root length is equal to or greater than the crown height. In stage G, the apical apex of the root is partially open, and in stage H, the apical end of the root canal is closed. Now in 1983, Krister Engstrom et al. They correlated developmental stages of mandibular third molar with skeletal age assessment by the hand raised radiographs. So the developmental stages of lower third molar were determined by OPG and were characterized into following stages. The stage one, the tooth germ is visible as a rounded radiolucency. In stage two, the cusp mineralization is completed. In stage three, the crown formation is completed. In stage four, the root is half formed. And in stage five, the root formation is complete, but the apex is not closed. This is a radiograph which shows the ossification center which were used for the skeletal developmental classification, in which the first site is the proximal phalanx of the second finger, the second site is the distal phalanx of the middle finger, the third site is the middle phalanx of the third middle finger, and the fourth site is the radius. So in the PP2, lower third molar showed complete crown mineralization. In distal phalanx, during the stage of fusion between distal epiphysis and diaphysis of distal phalanx of the third finger, the crown still is incomplete in some subjects, but it has already attained full root length in other subjects. In the stage of capping of epiphysis and diaphysis in the middle phalanx of the third finger, the crown formation is completed in majority of the subjects. And in the stage of fusion of epiphysis and diaphysis in the radius, the crown is completed only in the one third of the subjects, and rarely the root is developed in one third, and the root has reached full length in the rest subjects. Now coming to use of occlusal radiographs for determination of the skeletal maturity. The article titled Maturational Evaluation of Ossification of Mid-Palatine Suture by Ravello et al., which was published in AGODO in 1994. This study verified that the mid-palatal approximation occurs more posteriorly during entire adolescent period. The orthodontic mechanics are more efficiently designed if more of the force value is expressed more posterior to the suture, and the suture is not completely closed at the end of adolescence. Now coming to use of CBCT for determination of skeletal maturity. So volume of cervical vertebrae can be assessed in the CBCT for assessment of skeletal maturity. So an article by Choi et al., cervical vertebrae body's volume as a new parameter for predicting skeletal maturational stages, which was published in 2016 in the Biomed Research International Journal. This article concluded that the increase in cervical maturity levels as a result of increase in volume is not consistent with second cervical vertebrae. Then the higher skeletal maturity levels are seen in women at all volume levels of the third cervical vertebrae. And the fourth change in the skeletal maturity levels as a volume of fourth cervical vertebrae increased was relatively consistent in all areas and the regions. And from this we can conclude that the fourth cervical vertebra has the highest correlation with the skeletal maturity levels, while the second cervical vertebra has the least correlation between the volume and the and the skeletal maturity levels. Now, in the article titled Mid-Palatal Suture Maturation Classification Method for Individual Assessment Before RME by Angeleri et al., which was published in AGODO 2013. In this article, they presented a novel classification system for individual assessment of stages of ossification of mid-palatine suture. So in stage A, we can see a relatively straight high density line at the midline. In stage B, a scalloped line can be seen at the midline. In stage C, two parallel scalloped line can be seen close to each other, which are separated by some areas of small low density spaces. In stage D, two scalloped lines with high density, which are separated by which cannot be visualized in the palatal bone. And in stage E, we cannot identify the lines. From this article, they concluded that in stage A and B, a conventional RME approach will have less resistant forces and probably more skeletal effects than at the stage C. And the fusion of the mid-palatine suture at stage D will prevent the sutural opening with RME in the molar region, even though the opening of anterior diastema can be observed. This will lead to skeletal transverse increase in the anterior maxillary region, followed by dental changes only in the posterior region. And in the patients in the stage B and E, these are better treated by surgically assisted RME. And the article title A Comparison of Accuracy of Skeletal Maturity Indicators Using Cone Beam Computed Tomography, Lateral Cephalogram, and hand wrist radiograph in Circumpubertal Dravidian Population by Munaf et al., which was published in World Journal of Dentistry in 2020. This article concluded that the cervical vertebrae maturation index using lateral cephalogram and CBCT they show high reliability. The skeletal maturity indicators using hand wrist radiograph show reliability in circumpubertal male and female subjects. The CBCT has highest accuracy when compared to hand wrist and lateral cephalograms for all groups and both genders. So, CBCT can be used to assess skeletal maturity indicators, and therefore, we can avoid an additional radiograph when CBCT is considered as an investigating tool for other orthodontic for the patients for other investigation purposes. So coming to biochemical methods for assessment of skeletal maturity. So, what is a biomarker? Biomarker is a biological molecule in the blood or other body fluids or the tissues, which is a sign of normal or abnormal process or disease or a condition. So, skeletal growth and maturation is an outcome of complex interaction between the genes, hormones, then growth factors and environment. There are various methods for assessment of biomarkers, which include enzyme-linked immunosorbent assay, that is ELISA, then radioimmunoassay and immunoradiometric assay. Now, the first biomarker we'll see is a growth hormone. In the article, growth hormone secretory dynamics in subject with normal stature, Costin et al. Concluded that in prepubertal children, highest growth hormone levels are, and in the pubertal subjects, highest values of growth hormone were distributed equally between the sleep and the wake hours. Now, the second one is the insulin-like growth factor 1. Growth factor 1 has been used as an indicator of growth hormone levels, and hence it can also be used as a marker of growth. In the article by Subhash Naik et al., the relationship between salivary insulin like growth hormone 1 and quantitative cervical maturational stages of skeletal maturity, that the salivary IGF-1 levels are lowest at the prepubertal stage, peak at the pubertal stage, and mildly decrease during the stage, and hence salivary IGF-1 can be used as an additional diagnostic tool to assess the skeletal maturation. This another article by Prerna Singh et al. Concluded that the IGF-1 levels are significantly higher in pubertal stages compared to prepubertal and postpubertal stages, and hence the IGF-1 levels might prove to be valuable skeletal maturity indicator. Another biomarker is parathyroid hormone related protein. So in this article, Hussain et al. Concluded that the mean serum PTHRP levels are significantly higher in late pubertal stages. The peak serum PTHRP levels they do not correlate with the early pubertal stages characterized by maximum growth increments, and the validity of serum PTHRP levels to predict the peak growth velocity is still questionable. Then another parameter is Indian hedgehog protein. The article of salivary hedgehog proteins levels and cervical maturation stages as growth indicator by Khalid Khan et al., which was published in International Journal of Applied Dental Sciences in 2019. In this article stated that the highest level of salivary hedgehog protein was observed during pubertal stages, and salivary IHH can be used for skeletal maturation assessment. Coming to cortisol, in this article, Jangam Soumya et al., they stated that the lowest salivary cortisol levels are seen in the prepubertal group and highest in the postpubertal group. There is sudden rise in levels seen from prepubertal to pubertal group and levels further raised to postpubertal group, and hence salivary cortisol can be used to predict the peak growth velocity. Now, alkaline phosphatase. So, gingival clavicular fluid alkaline phosphatase activity as a growth marker, a systematic review by Siddharth Sonamne et al., which was published in EPOS Trends in Orthodontics 2021. This article concluded that the GCF alkaline phosphatase activity is a reliable method of determining skeletal maturity indicator in growing children. This another article by Suchita Tarvade et al. Concluded that the salivary alkaline phosphatase level MP3F stages to MP3FG stages. There is a sudden peak in ALP levels at MP3G stage. The values decrease from H stage to I stage. And salivary alkaline phosphatase can be used as a biomarker for pubertal growth prediction. This another article by Vijaya et al. In which they stated that the highest levels were of alkaline in the prepubertal stage. Decreased levels with increasing phase of puberty can be seen, and along with the chronological age, body mass index percentile, salivary bony alkaline phosphatase level can be used to for prediction of pubertal growth phases. This article by Deepak Khade et al., The Reliability of Salivary Biomarkers as Skeletal Maturity Indicators, a systematic review, which was published in International Orthodontics in March 2023. They state that the salivary biomarkers can be used and adjunct for growth prediction during orthodontic treatment planning, along with other methods of skeletal maturity assessment. So, among all the skeletal maturity, all the biomarkers, salivary biomarkers, the insulin like growth factor 1 is a good reliable indicator for skeletal maturity assessment. So coming to advantages of biochemical methods, there is no radiation exposure involved in these methods, and these are non-invasive in nature, except when the serum is used as a sample. And the drawbacks of these methods are various chemicals are used in this method, and the various methods have various normal values, so which may be confusing at times. There is influence of systemic factors on these biomarkers. The different studies show peak at different stages of puberty. There is lack of clear classification based on level of these markers. There is lack of standardization, and long-term follow-up and longitudinal studies and with large samples are required. So I would like to conclude by saying that to take advantage of idea of first the magnitude, second its direction, and third the element of timing. So by using the element of timing of growth in conjunction with one's knowledge of magnitude and direction, one can readily transform the orthodontics to a profession of face forming as well as a tooth positioning. These are the references.